Thanks for coming tonight. My name is John Ludlow. I'm one of the urologists at Western Michigan Urological Associates, which is part of Holland Hospital and Lakeshore Health Partners. And I'm going to talk tonight about testosterone and testosterone replacement therapy. You know, we've heard a lot about testosterone in the media over the past 5 or 6 years, and it's a topic that is popular. It needs to be discussed. There's a lot of myths. There's a lot of misinformation, and I think it's something that that is important, not only from the standpoint of urology, but from the standpoint of general men's health. You know, I think one of the things about men's health, men have a tendency to not want to go to the doctor and to keep themselves healthy. Women, on the other hand, are sort of interesting. They go through their OBGYN and they maintain a sort of a regular health maintenance program through their earlier years. We sort of tread through things until we're 50 or 60 and start to have some problems and then find our way to the doctor. Usually, as in my case, my wife is grabbing me by the back of the neck and telling me to go to the doctor. But keeping ourselves healthy is an incredibly important thing, and it's not something that we've done as physicians. You know, we treat disease. We don't prevent disease, but we should prevent disease. And I think testosterone is one of those things that plays a role in prevention of disease and maintenance of health. So I'm going to talk about testosterone in general and go through a discussion here. I think one of the ways that we can most benefit from a discussion like this is to keep it a discussion. Meaning, if you have questions, ask questions. I don't need to run through 40 or 50 slides and people raise their hand. If you have a question while I'm talking about things, raise your hand and ask the question. I'll tell you what, I learned from you guys, and everybody else learns from your questions. So ask questions. I think it's really an important part of this whole discussion. And let's keep it as long. So what are the important men's health issues in 2015? Dietary health, health maintenance. Diet is incredibly important, keeping ourselves healthy. Cardiovascular health, obviously, keeping our heart and our vascular system healthy. Bone and joint health. PSA and prostate cancer. A lot of discussion about PSA and the utility of PSA and whether we should get PSAs. I think PSA is very important. Prostate cancer is an interesting disease. Yeah, go ahead. PSA is a good question. What is PSA? PSA is prostate-specific antigen. It's a blood test that helps us screen for prostate cancer. There are controversies about whether we should even be getting PSAs. And I will tell you flat out that we overdiagnose and overtreat prostate cancer to your detriment, to the patient's detriment. The flip side of that story is that 30,000 men will die from prostate cancer this year. And the men that are dying from prostate cancer aren't going to tell me that they were overdiagnosed or overtreated. We have a lot to learn about prostate cancer and understanding prostate cancer, and it's a topic that is on the front burner for us, and we should focus on that as well. In future discussions, that's what we're going to do.
Question?
Yeah. Yeah, the question is, should men on a yearly basis have a prostate exam? And I'd answer that in the following way. When I was in training down at Indiana University, which is a big urological cancer center, it's one of the biggest in the country, one of the professors I learned from said to me, the only person that doesn't need a rectal exam is the person that doesn't have a rectum. So that's how I'm going to answer your question. It doesn't hurt to do it that much. It's a little uncomfortable. But I'll tell you what, I examine everybody on a yearly basis, but I'm very good about making sure that I'm doing the right thing and talking to them about other options when it comes to abnormal exams or the PSA blood test, for example. So I would tell you, yes, you need a yearly rectal exam. Whether you need a yearly blood test for a PSA is a discussion that you need to have with your physician. It comes with some controversy. That's a good question. Benign prostatic disease. Benign prostatic disease is simply our prostates grow, we have some difficulties urinating. Erectile dysfunction, and we sort of look at that and we say, wait a minute, erectile dysfunction is not that big of a deal. Erectile dysfunction is a big deal. Erectile dysfunction is a vascular disease in most cases, very much like heart disease is a vascular disease, that heart attack is a vascular disease, stroke is a vascular disease. Erectile dysfunction just occurs before all those other things occur. So when I hear men, 40-year-old men with vascular erectile dysfunction, I tell them flat out they're higher risk of heart attack and stroke. And I can tell you, I've saved a few people's lives because we've talked about their erectile dysfunction and we focused on that. So it's not a trivial issue by any means. It's something we need to discuss. And then finally, testosterone, which is what we're going to talk about tonight. So what's the big deal with testosterone? Testosterone is a big deal. We know that testosterone has direct and indirect effects on almost every organ system in the body. Hypogonadism, that's low testosterone. Hypogonadism is the technical term for low testosterone. It's a crucial factor in patients with chronic disease states, heart disease, pulmonary disease, different types of vascular disease, liver disease. Low testosterone is very important in those disease processes. Shifting demographics, what does that mean? Shifting demographics is the increase in the number of people over the age of 65, basically. The baby boomers are getting older and getting higher in number. And baby boomers don't want to sit around and put their feet up and watch TV. We want to live our lives and do the things we want to do. And testosterone can play a role in that. And the bottom line with this shifting demographics is that I'm seeing more and more patients at older and older ages who want to live their lives and do the things they want to do. And this shifting demographics is important. There are more patients that are coming to my office. We know that 5 million men in the US are affected by low testosterone. Benefits of treatment can be significant. There is the issue of risks, and I put a question mark there because we don't really know all the risks of testosterone replacement. And I will tell you that there are a stack of peer-reviewed journal papers that support the use of testosterone and the benefits of testosterone replacement therapy. And there are about 3 or 4 papers that would suggest there are downsides to testosterone replacement therapy. And none of those papers carry any weight in my mind. So we still have some issues with risk. It's something we need to think about and discuss. But I would tell you that the benefits far outweigh the risks. It's a good question. It's a good question. The question is, a study came out a year and a half ago or so that talked about testosterone replacement and increase in the risk of heart attack and stroke. There were 2 studies. One study was from the VA. And if you look at that study, first of all, I would tell you that there are 30 medical societies in the United States that wrote to the American Medical Association and demanded retraction of the paper. This paper was in the Journal of the American Medical Association. If you look at the statistics, there were incorrect and significant errors in the statistics. And if you look at the statistics, really what they showed was that there was a 50% reduction in heart attack and stroke in men who were treated with testosterone replacement. So those papers, the 2 or 3 or 4 papers that we've seen, have significant flaws and errors, and none of us think that they're important or significant. But it's a good question. 4 to 5 million men in the United States have low testosterone. It's a significant disease process. Actually, this number is probably low. It's probably closer to 8 to 9 million men. So it's not an insignificant issue. So what I'm going to talk about tonight specifically, I'm going to talk about the regulation and physiology of testosterone secretion. How do we get testosterone in our bloodstream? I'm going to talk about testosterone deficiency in chronic disease states. We're going to focus on this thing called the metabolic syndrome, which is important, and we're seeing more metabolic syndrome in this country, and I'll talk about that. We're going to talk about testosterone replacement therapy in prostate cancer, testosterone replacement therapy in the aging male, as it affects sexual function, and then the options in testosterone replacement therapy. So this is the physiology of testosterone. It comes from cholesterol. So if you think you don't need cholesterol, you're wrong. You need cholesterol. Cholesterol is a good thing. Too much of it is not a good thing, but cholesterol is a good thing. And cholesterol gets changed through all these different things, and it becomes testosterone. And then in the male, a small amount of testosterone gets converted to estradiol, which is the female hormone. You don't want too much of that, but you want some of it because estradiol is important to our bone health. And if you get too much estradiol, other bad things can happen. but you do need a little of it, just like women need a little testosterone as well. The question is, as far as cholesterol and HDL, LDL, those are different forms. All I'm talking about is the compound cholesterol. That's all that it matters. And cholesterol gets converted in the liver to those different substances. We know that testosterone is the primary circulating androgen, and by androgen we mean the substance that helps us build up our muscles and our bones and some other things. These substances get secreted in the brain, they go to these substances in the testicle, and testosterone's secreted by those cells. The adrenal gland, which is a small little gland on top of the kidney, contributes about 5% of overall testosterone. We know that testosterone is pulsatile and diurnal, meaning that it gets secreted in sort of a rhythmic fashion. And that has a consequence as far as testosterone replacement, because if you come into my office and I give you a shot and you get a big burst of testosterone and it trickles down over 2 weeks, that's not necessarily a good physiologic way to replace testosterone. The problem is it's a good way to do it from the insurance company's standpoint. It's the cheapest way to do it. And that's how the insurance companies want us to do it. I don't like it, but it's maybe the best thing we have. And when you talk about finances and dollars and cents in healthcare, we're not talking about little numbers.
I have a question.
Yes. The question is, the shot is one way to replace testosterone. What are the other ways? I'll get into that. I'll go through that very specifically, toward a little bit deeper in the talk. We know that the highest concentrations of testosterone occur in the morning, and we know that when we measure testosterone in the bloodstream, it's not all the same. There's some of that testosterone is bound to other things and doesn't work. Some is partially bound and can work. Some is unbound and is very active, and it's different people. And so I can't, in many cases, just look at a total testosterone and say this is what you have. I have to look at some other things as well. Understanding how to draw testosterone, measure testosterone, and interpret testosterone is really an important issue. So this is just testosterone in our body, more or less. This is the hypothalamus, which is a part of the brain that secretes this substance that goes to this part of the brain called the pituitary, that secretes luteinizing hormone that goes to the testicles and makes testosterone. And that's sort of the simplistic way to look at it, but it's much more complicated than that, and it is a very complicated process. So how does testosterone work? It works in a couple of different ways. Number one, we can have what's called free testosterone, which is really the testosterone compound circulating in our bloodstream that gets incorporated into cells and does things to the nucleus or the brain of the cell. The other way, it can be converted to this substance called dihydrotestosterone, which is really very, very important. And that can be the more functional aspect. What's important about dihydrotestosterone, or DHT, is that when I remove your prostate, I take away your ability to make DHT. And in the past, we didn't think that was important, but it is important. The same thing happens when I irradiate your prostate for prostate cancer, and I can give you some medications that can inhibit the manufacture of DHT. Understanding DHT is important, is becoming much more important. There are some good studies done at the University of California, San Francisco, looking at DHT and understanding what DHT does for us. And we really used to ignore it, and now we're really focusing on it. There's a lot of question marks with DHT. So it's something that's on the front burner right now. And then finally, estradiol, which again is that female hormone which supports bone health. And really, that's an important substance as well. This is more of a complicated thing. This basically talks about how testosterone works and what it does to us. It's got to get incorporated into cells. So it attaches itself to the cell out here, and it gets incorporated into the cell and does complex things to the inside of the cell, which alters the way certain cells function. And I'm talking about your brain, your liver, your bones, your muscles, your heart, your vascular tissues, your erectile tissues, virtually all the tissues in your body. And all of those are important. So that's a little bit more complicated, but the testosterone's got to get into those blood cells one way or the other. So the direct effect of testosterone, that's how testosterone interacts with a muscle or with a bone or with other parts of the body. It has direct effects on muscle mass, on bone formation, on our ability to make sperm, and on sexual function as well as other parts of the body as well. And again, this DHT, although we talk about things like facial and body hair and scalp loss, baldness, prostate and erectile dysfunction and acne, we're finding that DHT does much more than just this. And it's becoming something that we're focusing on much, much more. And finally, estradiol, again, I really focus on bone health and atherosclerosis. Those are really important. If we aren't converting testosterone to estradiol, we're seeing more significant problems in bone health. And let's talk about bone health for a second. Somebody that falls and breaks their hip in their 80s has a significant mortality rate, a death rate from that fracture. And what we know is that men in their 80s have lower testosterone levels and consequently lower estradiol levels. So bone health is incredibly important, and the consequences of poor bone structure and strength can be significant. It's not a trivial disease. So let's talk about circulating testosterone. This is testosterone that's in our bloodstream. And it really comes in two forms, a bound form, and that's the form that has the ability to function. The bound form has no ability to function, and the unbound form, meaning the free testosterone. So we know that sex hormone binding globulin and albumin will both bind testosterone. If testosterone's bound to this sex hormone binding globulin, it's not working at all. So if I measure your total testosterone and it comes back 330, and you have an elevated sex hormone binding globulin, you probably have a very low testosterone level. So understanding how to measure this and how to interpret this is important. Albumin is a little bit different. When albumin binds testosterone, it does it in somewhat of a reversible manner. So it at times will be bound and times will be unbound. And in many cases, I'll look at patients' albumin levels as well to get an idea of what their free testosterone actually is. So what we refer to as the bioavailable testosterone is really the unbound and the albumin bound. The bottom line is that when I measure testosterone and it comes back equivocal, meaning it's in that middle range there, I really want to know what the unbound and the albumin bound is before I make decisions. We also know that there are certain disease states, thyroid disease, obesity, some other liver-related problems that elevate sex hormone binding globulin and then consequently lower testosterone levels. Although when you measure them, they can still look normal. So it can be complicated. And you can't just look at that number and say that's normal or that's abnormal. You have to think of the patient in the whole, and it makes it a little bit more complicated. Yeah, the question is there a separate test for the bound and unbound? And there can be. If I measure a total testosterone in somebody and it comes back 150, as an example, and I'll go into this a little bit later, that's abnormal regardless of your albumin or your sex hormone binding globulin. But if it's in that middle range where you're maybe just a little bit above normal or in that equivocal range, which we say between 300 and 350, then I want to do some more investigating to figure out whether there's an elevated sex hormone binding globulin, what the albumin looks like, and I can calculate the free and the total testosterone that way. So there are certain ways that you can do that. You have to have a good relationship with the lab. I've got to be able to talk to the lab and understand what they're measuring when I look at those equivocal numbers. This again just represents the total testosterone. We know that about 60% is pretty tightly bound to sex hormone binding globulin, 38 to 40% to albumin, and about 2% is free. And that changes depending on disease states and some other issues. So let's talk about measuring testosterone. Timing is important. And we've gone back and forth over this. Do you do it first thing in the morning? Do you do it fasting? Can you do it anytime? The Endocrine Society came out with some guidelines. And the guidelines state right now that you have to fast from midnight the night before and preferably draw the testosterone level between about 9 and 11 o'clock in the morning. And if we all go by those rules, we're going to be able to reach some consistency in determining who has low testosterone and who doesn't. So I'm pretty good about making sure that that's what we're doing. And that can be a convenience issue as well. People work different shifts, and sometimes that's not possible to fast from midnight and to get the blood drawn in the morning. But that's the typical rule at this point in time. Again, testosterone may be affected by sex hormone binding globulin. There's this thing called equilibrium dialysis. This is something that's of interest only in certain scientific studies. No lab, Spectrum is not going to do it. The Mayo Clinic is not going to do it. There are specialized labs. There's one at UCLA in Los Angeles that will do this. There's one at Harvard in Boston. There's one down in Texas where we can actually measure the free testosterone, that free portion. Most often when I'm looking at that, I'm going to do that, look at the free testosterone in a calculated manner. These are some other assays that look at total testosterone. And again, these endocrine society guidelines are incredibly important. And I follow them to the T. I think we all should. All of us that are seeing patients with low testosterone and evaluating them and recommending treatment to them should follow these guidelines. One of the questionnaires that we have used in the past is the Androgen Deficiency in Aging Males, the ADAM questionnaire. And this is a good way to assess symptoms of low testosterone. Because when do I treat someone with low testosterone? I treat them if they have a low testosterone and they have symptoms of low testosterone. And those may not be one and the same. Somebody can have a borderline level of testosterone and have none of these symptoms, and I'm probably not going to treat them. And then I have somebody that's got maybe a low normal level of testosterone who has a lot of these symptoms, and I am going to treat them. And I think this is very reasonable. And this becomes very important from my standpoint in evaluating patients, but also from a practical standpoint. When the insurance company says to me, we're not going to pay for that person's testosterone because they're in the normal range, and their testosterone is 351, not 349, I'm going to talk to them about this study and this questionnaire and show them that the patient's symptomatic, and they're going to have to pay for the treatment. So it becomes somewhat of a practical thing at certain times. So what are the types and causes of low testosterone? Primary low testosterone or primary hypogonadism is due to testicular failure. And there's a variety of different things that can cause testicular failure. Things that we know about, like having had the mumps as a child, certain types of surgical procedures, certain types of medications and chemotherapy. And there's a lot of testicular failure that we don't know about. Maybe some environmental exposure or injuries or certain types of activities. Secondary hypogonadism or secondary low testosterone is due to either hypothalamic or pituitary problems. So that's in our brain. The hypothalamus secretes a substance that goes to the pituitary, which secretes a substance which tells our testicles to make testosterone. Most low testosterone is combined, meaning there's a primary and a secondary issue. But I can do some very simple blood tests to figure out which is which. There are also some congenital issues, Kallman syndrome, and certain types of acquired issues where there's tumors in the pituitary gland or something along those lines. Those are a little bit more specialized. I will sometimes get specialized MRIs of the pituitary gland called the sella turcica to figure out whether somebody has a pituitary tumor. I have a handful of patients that have pituitary tumors that secrete prolactin and create low testosterone. And those don't need to be treated with testosterone. They need to be treated with a different medication that treats the pituitary tumor. So it can be somewhat of a complicated process, but understanding it start to finish allows me to evaluate patients more correctly. So what does testosterone do? Male sexual function, obviously, erections, desire, libido, the quality of sexual interaction, all is affected by testosterone. Anabolic effects. Anabolic simply means building you up, strengthening muscles, strengthening bones. Hematologic effects. This is the quality of your blood. This is something that sort of relates to why do cyclists abuse testosterone? Because it increases their oxygen carrying capacity in the bloodstream. Bone metabolism, which we've already touched on. Mood and cognitive effects. These are important. So mood, good mood, bad mood, things like that is fairly simple. Cognitive effects are important though. We're seeing an aging population where there are patients who are still very, very functional but may have the start of Alzheimer's and dementia, which can be debilitating and significantly problematic. We can see some significant benefits in early Alzheimer's and dementia when those patients have recognized low testosterone and supplement them. And we can improve issues with their cognition and their ability to function on a daily basis. And if we can keep people independent at an older age, that's an important benefit. Insulin and cardiovascular effects. This is where some of the controversy is, but there are numerous studies that support the benefits of testosterone in dealing with and the development of diabetes and cardiovascular diseases. And I'll touch on those as well. Let's talk about sexual function for a second. Testosterone enhances sexual feelings and sexual activity, spontaneous erections. It gives us our libido, our desire. So when somebody comes in and talks to me about their erectile dysfunction, one of the first questions I ask them is, do you have desire? Because that's a good barometer of their testosterone level. We know that testosterone is more important in spontaneous versus any stimulus-induced erection. So again, one of the questions I ask patients in deciding whether to evaluate them for low testosterone is, do you wake up in the morning with an erection? We know that testosterone plus these medications, which we're all familiar with, that's Viagra, Levitra, Cialis, Staxin, and Stendra, we know that that may be beneficial. There are patients that don't respond, that did and don't now respond to these medications, who we supplement, and then they consequently respond to those medications. And we know that testosterone gives a quote-unquote better erection. It improves blood flow. It improves cavernosal smooth muscle. That's the vascular and smooth muscle within the erectile bodies in the penis. And we know that it participates in veno-occlusion. So one of the causes of erectile dysfunction that I see commonly is venous leak erectile dysfunction. Blood flows into the penis, but it doesn't stay there, it flows right back out. And that can be due to a lower testosterone level. And supplementing testosterone can cause those blood vessels to close and allow the engorgement of the penis to occur. Let's look at the anabolic effects, the things that build, what builds us up. Testosterone increases lean body mass. Lean body mass is important. Lean muscle mass is important. And we're talking about muscle and bone mass. We know that testosterone decreases all types of fat, but specifically truncal fat, the stuff that's right here. This is where men get fat. Men get fat here in the belly. Women get it in the buttocks and the hips and the thighs. That truncal obesity is one of those things that we'll see, and I'll notice men with truncal obesity who consequently have low testosterone. We know that testosterone affects mesenchymal stem cell differentiation. So basically what that means, the mesenchymal stem cells are the sort of the embryologic cell, the cell that creates all the other cells in our body. So we know that if testosterone has a positive effect here, it's at the beginning of our cell formation. And that can be very important. That's an area that is stimulated with a lot of research as well. So it's something that we're going to see in the future. Hematologic effects, that's your bloodstream. We know that testosterone can improve hemoglobin, hematocrit, red cell mass. This is, again, the Tour de France thing. And this is where people abuse testosterone. It ups their oxygen carrying capacity, and they can be more competitive. And we know a lot of cyclists have abused testosterone. The hematologic effects are more profound in the elderly. We know that. So what I'll see in older guys who I supplement testosterone, their blood counts go up. They have more energy in many cases with that. And we know that this effect, what's called erythrocytosis, or increasing that oxygen carrying capacity, it occurs more profound with injections of testosterone than patches or topical preparations, things like that. And this can actually be problematic. I have some patients on testosterone replacement who are getting injections on a regular basis, and I have to stop it because their blood count is going too high. If the blood count goes too high, they are at risk of stroke. So I have to be very careful in following those men. And sometimes we'll do different types of therapy in those men. So the question is, how does testosterone affect insulin? I'll get to that, but what we know is that there have been numerous studies that show men with lower levels of testosterone have higher requirements, diabetic men have higher requirements in testosterone or in insulin replacement. There are numerous studies that show that. So what we think is that testosterone has some effect on the pancreas, and we're not sure why. It may be related to that mesenchymal stem cell effect that allows the pancreas to be more effective in producing cells, islet cells, that make insulin. But it can be complicated. But it's a good question. What about bone metabolism? There are multiple pathways, but the bottom line is that testosterone supplementation can positively affect bone metabolism and make our bones stronger. We know that there are studies that show that lower testosterone levels increase the risk of hip fracture. The question is, does testosterone replacement decrease the risk of subsequently getting a hip fracture? No studies have shown that, which is interesting, and we're looking for studies to confirm this. And it's probably studies that are soon to be done and soon to come out. The bottom line is bone strength is certainly augmented in patients who have normal testosterone levels or who are on testosterone replacement. Well, let's look at mood and cognitive effects again. Again, I talked about dementia and Alzheimer's. We know that mood is improved on testosterone replacement. The effects on depression, though, are a little bit unclear. There's some resistance to treating depression when men are borderline or have normal levels of testosterone but have significant depression. Is it reasonable to supplement them? And no studies have shown that. We know, again, with cognition, especially as it relates to early onset Alzheimer's and dementia, that there's a benefit in testosterone replacement therapy. So insulin and cardiovascular effects. Testosterone has a vasodilatory effect, meaning that it opens up the blood vessels. So you open up the blood vessels, you get better blood flow to the things that need blood, like your brain and your heart and your liver and your muscles and your bones and the parts of us that maintain our intimacy. We know that there's an inverse correlation between testosterone and cardiovascular risk. So the lower your testosterone, the higher your cardiovascular risk, meaning the higher the risk of heart attack and stroke. And it's not the opposite. There is an inverse relationship between testosterone and that visceral fat. So the lower the testosterone, the more visceral fat. And visceral fat may have consequences regarding resistance to insulin and requiring more insulin therapy. Bottom line, right now we know large populations-based studies need to be done. Those are ongoing as we speak. What about chronic disease states? Chronic disease states, probably this is number one, cardiovascular disease, but also malignancy, HIV, AIDS, obesity, and the metabolic syndrome. We know that in these disease states, these chronic disease states, low testosterone levels are common. And understanding that and being able to evaluate patients with cardiovascular disease, with obesity and the metabolic syndrome, malignancy is a common thing. I see it all the time. Patients come in who have certain types of malignancies and low testosterone and have a much better response to their treatments for their malignancies if their testosterone is supplemented. Well, let's look at the chronic disease states a little bit more. Why is testosterone low in these chronic disease states? Centrally mediated effect, meaning that it's up in the brain. And we know that with stress and malnutrition, with pain medication usage, with infections, which are all common in chronic disease states, that there's a centrally mediated effect that can lower the secretion of certain substances in the brain that leads to lower testosterone levels. We know there's a direct effect on testicular tissue, meaning that the testicular tissue is damaged and testosterone's not produced like it should be produced. And all of those have a deleterious effect in these chronic disease states. We know that in malignancy, 50% of men being treated have low testosterone levels. There's 3 or 4 good studies showing this. And we also know that with chronic opioid use, that's pain medication. So narcotic use in patients with chronic disease states, specifically malignancies, we know there's a decrease in testosterone. Right now, my focus is seeing patients who have these chronic disease states, especially these malignancies. They need to be evaluated correctly and treated if their testosterone levels are low. Yeah, it's a good question. The question is, are there medications out there that can lower the testosterone level? There's really one class of medications that we know definitively does that, and those are narcotic medications. So what narcotic medications do is they go to the brain and they tell the brain to not secrete a substance called gonadotropin releasing hormone, GnRH. So GnRH is this substance that is secreted by the hypothalamus, which is this little gland inside our brain, right in the center of our brain. And that goes to our pituitary and tells our pituitary to secrete luteinizing hormone, which then goes to the testicles and says secrete testosterone. So if I block your gonadotropin releasing hormone, your testosterone will go down. One of the classic treatments for prostate cancer that is spread to the bone is to give patients a medication that will stop their hypothalamus from secreting gonadotropin releasing hormone. So opiate medications are the common medications that can do that. There's very few other medications that will interfere with testosterone production directly. Now, you can look at certain types of chemotherapeutic agents that will have a direct effect on testicular tissue and prevent them from making testosterone, but those are fairly infrequent and not very common. The oral pain medications are probably the most common. That's a good question. The question is, what about anxiety medications and their effect on testosterone? And I will tell you this, that's an area that I'm going to say I don't know. And none of us know. I will tell you that flat out that there is anti-anxiety medications, and there's a variety of different types of those medications. And you can look at antidepressant medications and the newer forms of antidepressant medications versus the older ones, the newer anti-anxiety agents versus the older ones. They all have a centrally, they're all active in the central nervous system to some extent. And they can interfere with certain substances in the central nervous system that can have a negative impact on testosterone production. It's just that it's going to be different in different people, and we just don't know the answer to that right now directly. Yeah?
What about THC?
Yeah, the question is, what about THC? So tetrahydrocannabinol is basically marijuana. And that's an area that in some patients, depending on their other medical issues, there can be some deleterious effects on testosterone production as the result of using THC. Now, the other question is going to be what form of THC. There's an edible form, there's liquid form, there's an injectable form, and there are an inhaled form. And all of those can react differently as far as their impact on testosterone. Not enough studies have been done to show it. And because of the changes in society and how we're dealing with THC, is something that we're going to focus on sometime in the future. That's a good question. So let's look at the metabolic syndrome for a second. What is the metabolic syndrome? It's common these days. I see a lot of patients with it. And it's also known as Syndrome X. So the metabolic syndrome is obesity, elevated triglycerides and glucose, lower high-density lipoprotein, that's the good cholesterol, high blood pressure, and low testosterone. And I see patients with this all the time. It's common. And these patients with metabolic syndrome are rarely evaluated for testosterone. Almost all of them have low testosterone. And almost all of them can benefit from testosterone replacement therapy. The Massachusetts Male Aging Study was a big study done back in Boston. We know that there was an increased risk of the metabolic syndrome in men with lower testosterone levels. Finland had a great study, a great population-based study. Men with lower testosterone level were at increased risk of both metabolic syndrome and diabetes. And what they also found was that testosterone replacement in those men helped correct these maladies. So multiple studies document the benefit of replacement therapy in both the metabolic syndrome, and we know that it's protective or preventive when it comes to metabolic syndrome and cardiovascular disease. What about prostate cancer? 220,000 men are going to get diagnosed with prostate cancer this year. It's a lot of people. It's the #1 solid tumor that kills men in the United States right now. And what we know, despite what we've heard, this is by Dr. Cully Carson, who's a urologist back at Duke. There's currently no evidence that testosterone replacement therapy initiates prostate cancer or stimulates subclinical malignancy to become clinically evident. Basically what that means is that if you have prostate cancer and we don't know it and we give you testosterone, it's not going to make you worse. I have a number of patients with prostate cancer who are not being treated for that disease, because not everybody needs to be treated if they have prostate cancer, who are on testosterone replacement therapy and are doing fine. Their PSA blood tests have remained the same. Their follow-up biopsies have not progressed. Testosterone replacement therapy in prostate cancer is fine, treated or untreated. And we know that definitively. There are numerous studies that show that. Testosterone replacement therapy might increase prostate volume, meaning it might make the prostate grow a little bit, but there's a lot of things that make the prostate grow, that mediate prostate growth. Testosterone is just one of them. We know that PSA levels, so that's the blood test, prostate-specific antigen, are decreased in men with lower testosterone, and when their testosterone is replaced, their PSA goes back up. But that does not have that is not consequential to the development of prostate cancer. So what we know is that the prostate is stimulated only to a certain level by testosterone. And it's a relatively low level. It's less than 100. So the number of patients that I see with low testosterone, the percentage that have a testosterone less than 100 is less than 5%. Most patients are above that. So their prostate is maximally stimulated. The majority of patients' prostates are maximally stimulated even if they have low testosterone. And supplemental testosterone doesn't mean that I'm going to stimulate their prostate more. And that's a really important concept. I still have colleagues that don't want to give testosterone replacement therapy in men because of a risk of prostate cancer. And that's erroneous. That's wrong. And the patients are losing the benefit of testosterone replacement therapy in that setting. So there was a study that was done. 10 patients had their prostates removed for prostate cancer. They were found to have low testosterone, and they were treated. None of them had an increased PSA, but they all had significant improvements in their quality of life. From my standpoint, I always follow prostates and PSAs in men who are on testosterone replacement therapy, and more because of a medical legal issue. I see very few problems in patients on testosterone replacement therapy as it pertains, or testosterone replacement therapy as it pertains to the prostate. It's really a myth, and unfortunately we have to focus on this because there's still a lot of physicians that don't understand this. So bottom line, most studies suggest no association between testosterone and the incidence of prostate cancer. That is really the bottom line. So let's look at testosterone replacement in the aging male. The aging male is a common entity in my practice. I see more and more patients in their 70s and their 80s and their 90s that want to live their lives. They want to be active physically. They want to be active mentally. They want to maintain their intimacy. They don't want to sit in the corner and curl up. They want to live their lives. And it's a good thing from my standpoint. This segment of the population is increasing. 15,000 people turn 65 every day in the United States. It's a huge segment of our population. The majority of my patients are in their 60s and 70s and 80s and 90s. And I see guys in their 80s that come in and have questions about sexual dysfunction and testosterone, and it's a good thing. 5 million men at least, probably closer to 8 to 10 million, have low testosterones. 5%, and this is a little bit of an older number, it's probably more right now, 5% are really receiving replacement therapy at this point in time. What percentage can benefit from testosterone replacement therapy is, who knows? But because of a variety of things, they aren't being evaluated and aren't being treated. We know that testosterone secretion decreases with age. The short-term consequences, diminished libido, maybe some mood-related issues. I shouldn't probably put depression here, but mood-related issues. Longer-term consequences, bone loss, loss of muscle mass, cardiovascular risks, diabetic issues, obesity, cognitive dysfunction. So again, this baby boomer population is growing and they have a strong desire to remain active, and they should. So again, the prevalence of hypogonadism, low testosterone, is underestimated. And it's certainly an unrecognized and unappreciated condition. You know, I somewhat harp on my primary care colleagues, but they have a lot on their plates. They see patients with their high blood pressure and their cholesterol and their diabetes and a lot of different things. It's hard for them to include testosterone and hypogonadism in the evaluation. So I say send them to me. I can see them and deal with it, and I'm more than happy to do that. We know that testosterone levels begin to decrease between the age of 30 and 40. And we know that they decrease relatively significantly, so that at the age of 80, at least 50% of men have low testosterone. And a lot of those men are going to benefit from testosterone replacement therapy. So why is it that only 5% of men in the aging population who are hypogonadal, who have low testosterone, why is it that only 5% receive therapy, evaluation and therapy? It's your fault and it's my fault. I hate going to the doctor. A lot of men are that way. I think that's changing, but it's still you got to come in, you sit and you wait, and I'm late, and a 15-minute visit turns into 2 hours, and nobody likes that. Yeah, I think what you're asking is about the specifics of replacement therapy. That's your question. I'm going to get to that in 2 seconds. All right. Those symptoms are a normal part of aging. That's sort of me. I'm saying that to you, and I don't do that. But me being physicians, you know, we say that when people come in and they're a little bit overweight and they're tired and they've lost their energy level and they're losing their desire for intimacy, and well, that's just a normal part of aging. You're 80 years old, you're 70 years old, who cares? We should care, because that's why you're here. We want to improve your quality of life. That's our goal. We know that testosterone's incorrectly assessed or not assessed at all. And then perceived risks of testosterone replacement therapy, prostate problems, cholesterol problems, cardiovascular problems. But what I've said and what I'm going to say again is that those are myths. And those are myths, and I'll say that every day. The treatment approach in the aging male, we want to improve libido, mood, feelings of well-being, energy level, muscle mass, preservation of bone mass. And we know subsequently that testosterone replacement therapy can protect the heart in men as they age and who are receiving testosterone replacement therapy. Contraindications, when is it that you're going to come and see me and I'm going to say you can't have testosterone? Pretty rare, to be honest with you. If it's low, I'm going to treat you probably. Prostate or breast cancer, and breast cancer can occur in men. Those that aren't actively treated for prostate cancer, I may have some reservations about treating, but again, it's very much individualized. Prostate growth and urinary issues are probably not exacerbated significantly with testosterone replacement therapy. We used to think that if you had sleep apnea and I treated you with testosterone, your sleep apnea got worse. There's 2 good studies out in the last year that show that that's not the case. Men with congestive heart failure may be at some risk, especially as it relates to the blood count and increasing the blood count. But all of those are relative. There's very few men I look at who have low testosterone and say, you can't be treated. It's a pretty rare occasion that occurs. I'll skip over this one. So we know specifically when we talk about testosterone and libido or desire, one of the questions is libido or sexual desire correlated with overall well-being? A couple of studies have shown that. that if we have a strong libido, our sense that our lives are good, even if we're not sexually active, is much better. We know that libido parallels testosterone secretion, and those studies have been confirmatory and don't need to be repeated. How about erectile function? And this is an area 25 years ago, anybody that had erectile dysfunction, we treated with testosterone replacement, correctly or incorrectly. So that wasn't really right. And we know that eunuchs, those that lose their testicles before puberty, still were able to get erections. We know that testosterone facilitates cavernosal smooth muscle. So cavernosal smooth muscle is the structure of our penis that allows us to get an erection. And we know that men with lower testosterone levels, and especially men who have lost their prostates and no longer have DHT, dihydrotestosterone, have significant loss in the quality of their cavernosal smooth muscle. Their penis shrinks. That's the bottom line. We know that testosterone supplementation can be vasodilatory and can improve the structure and the function of the penis after prostate removal in certain cases. And again, I talked about this salvage therapy. So what I have is I have men that come in who have been treated with Viagra. And they'll tell me that I used to use Viagra, it worked great. And now it doesn't work anymore. And there's a percentage of those men who have underlying low testosterone who are then supplemented with testosterone who will find that Viagra will now work for them. So there's an interaction between the PDE5 inhibitors, that's Viagra, Levetiracialis, those medications, and testosterone. And we know that that combination therapy can sometimes be very effective in salvaging men who no longer are able to get an erection. So let's look at testosterone replacement options. How do we give testosterone to you? We give you injections. There are patches that you can wear. There are gels that you can put on your skin. There's a little thing that you can put right in your cheek, and it absorbs through the cheek. There are oral preparations, and there are pellets that go under the skin. All of those are options to a certain extent. This one is not in the United States. There are no oral preparations in the United States. The oral is rapidly metabolized, it's risky, and it's rarely prescribed, even overseas. I had a patient recently from India who had been on oral testosterone therapy. He has a higher risk of liver cancer. That's a big deal. That will kill you. So there's no oral preparations in the United States. The intramuscular injection, you come into my office once every 2 weeks and you get a shot in the butt. So what happens is you get the blast effect. The testosterone level shoots up and it trickles down over 2 weeks. And that is not what happens in our bodies, but because of insurance issues and convenience and other things like that, this is probably the most common way that testosterone is given. This is the brand new form of testosterone, the injectable in the United States. It's been around in Europe and Canada for a long, long time. It's been very effective. This is an every 10-week shot. So you get this shot of testosterone and it sits in your muscle and it slowly gets through your system over a 10-week period of time. And I can tell you that men who've been on the every 2-week injection, who we convert over the every 10-week, will tell me they don't feel as good. Almost every one of them. And it's just that you get that big burst and it makes you feel good. The transdermal approach, whether it's a patch or a gel, is the most physiologic because you put it on every day and you get some testosterone every day and you get a better steady state of testosterone. The problem is you're probably going to pay $400 out of pocket monthly for this. And the majority of us can't afford that. The subcutaneous, this is a little, I make a small little incision over your back pocket in your buttock, and I put some pellets, and the pellets slowly leach out over 3 months to 12 months. The majority of patients about 6 to 9 months. So those are the options. As far as monitoring, I do some tests and I see patients on a regular basis afterwards to make sure that things are okay. So again, the oral preparations, we're going to just ignore these. There are no oral preparations. You can't take a pill and correct your testosterone. There is one exception there, there's a medication called Clomid. So what Clomid does is it stimulates our hypothalamus, which then indirectly stimulates our pituitary and makes our testicles make testosterone. None of the insurance companies will pay for Clomid. I can sometimes use it in patients who are infertile, but it's tremendously expensive. I use it in a few younger patients, but it's not something that really can ever be used. So the oral preparations are not available in the United States. Still worldwide, a lot of people use it. This is, again, the injection options. I use testosterone cypionate. That's the one that most people use in the United States. If you lived in London, you'd get this one. And that's just the way it is. There's no testosterone cypionate in London, and there's no testosterone enanthate here in the United States. And they're almost the exact same. I'll tell you that they're slightly different in their chemical composition, and when they're manufactured, they are in an oil, and the oil in enanthate is different than the oil in cypionate. The bottom line is they're very similar. This is the longer acting one that has been around for a long, long time, but just FDA approved. So the testosterone cypionate is relatively inexpensive. It's effective. You get the burst and you trickle down over 2 weeks. Most patients are on a once every 2 week, and that's the standard recommendation. Once a month, it doesn't work. You're gonna be low for a long period of time, or you're gonna get such a high dose to begin with that you'll have other negative side effects. All of the injectable ones, the cypionate, are going to cause some potential to increase your blood count, like I talked before. People note that their symptoms somewhat fluctuate. And technically speaking, you got to come into my office and get an injection. And that's a nuisance. I know it. But despite those downsides, this one is the most popular. The patches, there used to be a scrotal patch that nobody ever uses. You know, can you imagine sticking a patch on your scrotum every day and taking it off? And I don't think I have to say much more than that. But it was provided significantly helpful symptomatic relief. The androderm patches, these are non-scrotal. They go on your stomach and they leave a welt. And I can, if you took your shirt off, and you'd have 8 welts on your body and they itch. And it just made no sense. People don't use them much anymore at all. Some people like them, but most people don't. The gels are the ones that, again, I think we should use most often, and they're the ones that make the most sense. The problem is they're expensive, and the drug companies know it, and they're making a lot of dollars on these medications. Most of the insurance companies really balk when it comes to these, and you got to have a lot of reasons to convert someone from the injectable to these. So there's Androgel, there's Testum, there's Axiron, Fortesta, and there's compounded formulations, which probably aren't as effective, but are much cheaper. So there are compounding pharmacies. There's one in Flint called Diplomat. It's actually, there's one in Grand Rapids. There's one up in Wisconsin called Women's Health, but it's for men as well. I don't know why they call it Women's Health. But there are compounding pharmacies that make their own testosterone. It's much cheaper, but it seems to be less effective in some regard. Relatively convenient, but you got to put it on every day. Really no skin irritation for the most part. The gels can be transferred to others. So if I'm putting Androgel on my chest and then hugging my wife, I'll notice she gets a deep voice and a little bit of a beard, and I'm not sure I'd like that. But so you have to be careful with that. There can be drug accumulation where the levels get very high. There are differences in how effective they are in some patients. And there are some patients where, when you think of the skin's a barrier. So when I'm putting something on my skin, it's not being absorbed. That's how our skin works. But these substances have compounds in them that allow the testosterone to get through the skin. Some people it doesn't work very well, though. Their testosterone levels don't go up at all, and they're telling me they're using a lot of this gel on a daily basis, and their testosterones are still low. Some people don't respond to them. The buccal discs, that's the thing you put in your mouth. is I think I've probably used this 20 times, and everybody complained about it. Their gums irritated. It was difficult to eat and drink. And it was relatively effective, but it's just not practical. The Testosterone pellets, again, 10 to 20 pellets under the skin in the buttock. It's about a 3 or 4 minute procedure, a little tiny incision. And most patients, they will have a great testosterone level for 6 to 9 months. The problem with this is that the insurance companies, again, want to balk at this. I have probably 25 or 30 patients on this. Most of them do great with it and love it. Some pay for it, and some their insurance companies pay for it. So to wrap things up here, I appreciate everybody's patience. We know that, number one, testosterone is the primary male androgen. That's the male hormone. We know that low testosterone is a common problem. Short and long-term effects of low testosterone can be significant. Whether you're talking about your libido and your sexual dysfunction, or you're talking about effects on your muscle mass and your mood and your heart and your bones and your brain and things like that. We know that the assessment is straightforward, but it's got to be done correctly. Treatments are varied and relatively straightforward, whether it's an injection or a topical or a pellet. There are options. Treatments have really acceptable and what I would say fairly minimal risks. So it's a process that I think deserves a pretty ample discussion when you're talking to your physician. But it's got to be evaluated correctly, and all the treatment options have to be discussed with you. So it's not something that you can just take a 2-minute discussion and head to the next patient. It's something that needs a little bit more attention. I'm willing to answer questions. I can stay up here as long as everybody wants. Yeah.
How is the assessment done?
The question is, how is the assessment done? Blood test. It's a morning. Again, you got to have a blood test. Fasting from midnight the night before, first thing in the morning.
So you
Simple.
make an office appointment?
You can get a blood test. It's very easy to get done. And the way that we like to do this, what we do is we follow the Endocrine Society guidelines. So the specific guidelines are that if you have your first blood test and it comes back less than 300, that's low. And by definition and by following the guidelines, we repeat it, and we also get a luteinizing hormone. So that tells me whether you have primary or secondary, if it's the testicle or your hypothalamus or pituitary, and that gives me some indication of why it's low. So 2 consecutive testosterones less than 300, that's low and deserves treatment.
About that.
Yeah, it's a good question.
Positive towards
Yeah, the question is, what about our diet and what about supplements? You know, the problem with supplements is that there are so many of them and they're not well studied because the FDA says based on a supplement, you don't need these studies other than to look at their safety factor. But do they have a positive impact on testosterone? They could. And if you go into GNC or any health food stores, they're going to have a variety of things that they're going to tell you are going to increase your testosterone. Whether that happens in you or not remains to be seen. You know, from a diet standpoint, I'll be sort of broad and general. I will tell you that a low-fat, low-salt diet, especially avoidance of high sugar in your diet and processed foods, and that's hard. You know, if you walk through a supermarket, and I picked up some salad dressing, and the number one ingredient in the salad dressing was high fructose corn syrup. That's a simple sugar that's going to have some negative effects on my pancreas, and if you're constantly eating those medications, that can be a big problem. Diet's a huge issue. It's one that we as physicians have ignored for a long, long time, but is incredibly important. Yeah. Yeah. Yeah, the question is about treating that. If you have low testosterone, I can't correct it I can give you the medication. It's something where you're going to have to keep seeing me over a long period of time. I'm not sure if that's what you were getting at. Yeah, it's more or less, there's not a permanent fix. And you know, that's a good question. Once you embark on treatment, do you have to be treated for the rest of your life? That's up to you, really. If you're seeing the benefits of treatment, should you continue to be treated? And the answer is probably yes, but But at what point in time do you say, I'm done? I don't know the answer to that. The question is, most of the patients that I treat been with me for a long time. Yes and no. I get a lot of new patients. The way our practice is set up is there's 4 of us. We do the things we want to do. So we aren't jacks of all trades. There are the things that I like to do, and Dr. Traver and Dr. Willoughby and Dr. Bates do the things that they like to do. And it's better for the patient because I'm seeing and evaluating doing the things that interest me. I'm less interested in the female aspects of urology, whereas Dr. Bates does that. So most of the patients that I see for testosterone replacement therapy are going to be with me for a long time. So that's sort of the quick answer to that, or the long answer. Yeah. The question is, how does testosterone impact sickle cell? It doesn't. It's not going to make it any worse or better. And there have been studies that have looked at that. So if you've got sickle trait, or if you have sickle disease, it doesn't change things at all. That's a great question. Yeah, since this is a steroid, are you gonna get in a bad mood or do bad things on testosterone? Well, cholesterol is a steroid. So if you eat a high cholesterol meal, that doesn't make you angry, I guess, for the most part. If your testosterone level is 2,000, yeah, that will make you angry. No two ways about it. But at a normal dose, if you come in and are getting 200 milligrams every 2 weeks, your peak level is going to be about 400 to 500. That's a normal level. The high range of normal is about 800. I've had patients that have come in and have testosterone levels of 2,000. Not because I'm giving it to them. It's usually patients that are abusing it one way or another. They're either getting it on the street, or I do have patients that can give themselves their own testosterone. Their significant other's a nurse or something along those lines, and they have a tendency to abuse things now and again. I have a number of patients that I've seen that with.
Another question. Are any of the gels nearing the end of their patent period where they become generic?
No, that's sort of a myth about the patent stuff. You know, if you look at something like Viagra, so what's going to happen when Viagra loses its patent, the pharmaceutical that picks it up and starts to produce it and make it, they're not going to lower the price. They're going to keep the price the same. It's the same with testosterone. As soon as that happens, they're going to continue to charge that price. They can charge the price they want.
Other manufacturers.
The competition plays less of a role because of the way the patents work in the pharmaceuticals. So the corollary to that is the compounded stuff. If you can get the compounded stuff at a significantly lower price, which you can, the question is, will you respond to it? And it has to do with how it's made and how it gets through your skin. So I can prescribe compounded testosterone to you through Diplomat Pharmacy, and they can send it to you in the mail. You could put it on every day, but there's a significant portion of patients that don't respond very well to the compounded forms. It's just less effective. So, but the answer, it's gonna come off patent to some extent, but the price is probably not going to go down. It can elevate your PSA. So the question is, if I give you testosterone, is your PSA going to go up? It might. But why is that a problem?
The doctor don't like the high PSA.
The more important question is, like we said, testosterone replacement therapy has no impact on the development of prostate cancer. And that's what PSA is for.
Yes.
So I would tell you, I follow it, but I don't worry about it. And I encourage patients not to worry about it. All right. It's a good question. Yeah. The question is, does this supplement cause kidney problems, or is it going to help your testosterone? The only way you would know is to measure your testosterone level before and after. And to be honest with you, that is a substance that there are hundreds of those. I'm not familiar with it.
I'd be willing to do a test if you're interested.
We could do that. That's easy. Before and after.
Yeah.
Yeah, the question is, you've got a blood test for testosterone and you're told it's normal. What does that mean? And that's a really good question. And it's a good question because if you get your blood tested and and you're told it's normal, my question to you is this: was your testosterone greater than 350? Because if you look at the normals on the result, the normals are going to be from 220 up to 850. So really that doesn't mean a whole lot. The Endocrine Society guidelines, the Endocrine Society in the United States is a group of endocrinologists in this country who are dedicated to endocrine issues in patients. They're smart people. Numerous studies have been done. If your testosterone is less than 300, that is abnormal. And I see patients all the time that were told their testosterone was normal. And it is if you look at the assay, based on what the assay numbers are. That's different than what the Endocrine Society says is normal and abnormal in us. So it behooves us as patients to know what that number is. That's key. Yeah. Yeah, the question is this part of a typical blood test? And the answer is probably no. They really have to do this specifically. A lot of blood tests that we as physicians order are panels. You order a Chem 12 or a Chem 17. Is testosterone a part of any normal panel? No. You have to specifically order a testosterone level, and your insurance company isn't going to pay for it unless it's linked to a specific diagnosis, or you're going to have to pay for it. That's why when you go in and get your blood test, sometimes they'll make you sign a form that says if your insurance company won't pay for it, you're going to pay for it. That's all this coding nonsense that we have to deal with. So unless your physician has specifically requested a total testosterone, you're not going to get one. The question is, I'm not sure how to phrase that actually. The big issue, your physician has to code things correctly or you're going to be responsible for things. It's a nuisance. So, yeah, I think your question is who really in the physicians, who's really the one that understands this and should evaluate it and treat it? I'm not going to stand up here and tell you that if you don't come to me, you're going to make a mistake. I think there's a lot of the primary care physicians that do a really, really good job with this. They have a lot more on their plate than I do. When you come in to see me, I can pretty much figure out what's going on in about the first 30 seconds and really have a game plan in my mind. The primary care physicians have a whole host of things to deal with. So I'm not going to look at you and say, you need to go to a urologic specialist to get yourself evaluated. I would talk to your primary care physician about it. And the primary care guys that I know here in Holland and that I deal with on a daily basis are pretty comprehensive and pretty good guys. And if they're uncomfortable or if you need it for your peace of mind and you want that evaluation through one of us, absolutely. You don't need a referral and all that stuff is done. You can call us and make an appointment. Yeah. Your statement is good. It has to do with referrals. Priority Health is the one insurance company that really digs their heels in when it comes to this. And the thing is, if you're in the Medicare age, it doesn't make any difference. You can come to me. You don't need a referral. So, you have a question? The question is faster muscle recovery with no, not with testosterone, not if you're in the normal range. No, you won't get faster muscle recovery. From exercise you're talking about? No, you won't. If your testosterone's in the normal range, you won't get faster muscle recovery. If you're no, they use it. The cyclists use it because of its oxygen carrying capacity. That's why they use it. Other questions? Yeah, you should be treated. The question is specifically history of prostate cancer treated and testosterone replacement. Your PSA is undetectable? I would have zero problem treating you. Zero. And if you talk to the person that knows the most about testosterone replacement therapy in the world, Abe Morgentaler at Harvard, who's incredibly bright, has done a number of studies, he will look at you and flat out tell you that you should be treated. And I hate to contradict what another physician has told you. I'm going to be honest with you. If you were my brother, and I like my brother, he's a good guy, I would tell you flat out, you need treatment. Yeah. Yeah, the question is, how does cardiology fare in all this? Again, I think that they have a little bit of a focus on what they do, but I talk to the cardiologists all the time about testosterone replacement therapy, and I've got good friends at West Michigan Heart that have been there for a long, long time and are proponents of testosterone replacement therapy in overall prevention and health, and they're very much a proponent of it. I would tell you that I think there are good studies to show that your vascular health and your cardiovascular health are augmented and significantly improved in men who are treated, men with low testosterone who are treated. Yeah, there's all sorts of studies that show yes and no. The question is if you ejaculate regularly or you can have a healthier prostate. There was a study that came out about 2 months ago that said if you ejaculate regularly, you're not going to get prostate cancer. So I left that on the counter for my wife. It's been an hour and a half. I know I appreciate everybody coming and listening. And testosterone is a great subject. It has some significant upsides. There's lots of controversy. It's a topic that we need to talk about. I appreciate everybody coming and asking questions. There's a good group of people. And if you have further questions, call my office and ask to speak to me. I'm more than happy to talk to you over the phone. All right. Thank you, everybody. Have a nice evening, good weekend, good holiday next week.